All right, welcome. In this explainer, we're going to do a high-yield walkthrough of breast cancer. We'll focus on the absolute essentials you need to know for your exams and for your clinical rotations. We're talking presentation, diagnosis, and of course, staging. So, let's kick things off with the classic clinical problem you're guaranteed to see. A patient walks in, they found a new lump in their breast. What do? What are the key steps in the right order to work this up efficiently and get the right answer? Okay, so first things first, we've got to be great detectives. And that means recognizing the signs and symptoms that should make your spidey sense tingle for malignancy. So let's break down what a suspicious breast mass really looks like. You know what's interesting? A lot of breast cancers these days are caught on screening mammograms, way before anyone can even feel them. But the palpable mass? It's still a super common way people present. But just feeling a lump isn't the whole story. It's the character of that lump that really clues us in. Okay, these are the four classic high-yield features you absolutely have to burn into your memory. A suspicious mass feels hard, like a rock, not soft or rubbery. It's immobile or fixed to the tissue underneath it. You can't just wiggle it around. It's often a single dominant lesion that stands out. And when you feel it, the borders are irregular or jagged, not nice and smooth. All right, now for the skin findings, and you really got to pay attention here, because these are huge red flags that often mean something more advanced is going on. Skin dimpling or retraction, a nipple that's suddenly pulled inward, and especially any kind of bloody nipple discharge, those should set off alarm bells. And then there's the classic one, Peau d'orange. The term peau d'orange, it's French, literally means skin of an orange, and man, it's a perfect description. What's happening underneath is that the tumor has grown so much, it's actually blocking the tiny lymphatic channels in the skin. This causes swelling and that classic dimpled look. If you see this, you're dealing with locally advanced disease. Okay, so you found a suspicious mass on your exam. What's the next move? We need to get imaging, right? But our strategy, our first step, is going to be dictated by one key factor, the patient's age. This is super high yield. I mean, write this down, highlight it, whatever you got to do. In women under 30, the breast tissue is typically really dense, and a mammogram can look like a whiteout. So for them, we always start with an ultrasound. For women 30 and older, the tissue is usually less dense, so we can start with a diagnostic mammogram, and we'll often follow that up with a targeted ultrasound anyway. So it doesn't matter if we started with the ultrasound or the mammogram, the end of the road is the same. If the radiologist sees something suspicious and calls it a BI-RADS 4 or 5, that's our cue, that's our green light. Remember, imaging can suggest cancer, but it can never, ever diagnose it. For that, we absolutely must get tissue. And that leads us right to what is, without a doubt, the most important step in this whole workup. We need a definitive answer, and that can only come from one place, a pathologist looking at those cells under a microscope. When you suspect an invasive cancer, the gold standard, and I mean the only right answer on an exam, is a core needle biopsy. This is way better than a fine needle aspiration, or FNA, because you get an actual, solid piece of tissue to work with. So you might be asking, why are we so insistent on a core biopsy? What's the big deal? Well, it's all about architecture. A core biopsy gives us enough tissue that the pathologist can see not only that it's cancer, but also how the cells are arranged. And crucially, it gives us enough material to run the biomarker tests that are going to guide our entire treatment plan. And that brings us to the big three. These are the biomarkers we have to check on every single invasive breast cancer. Is the cancer being fueled by estrogen or progesterone? That's your ER and PR status. Does it have way too many copies of a growth-promoting receptor called HER2? The answers to these questions are absolutely fundamental to how we're going to treat the patient. Okay, we've got our diagnosis, now we have to stage it. We need to figure out just how far this cancer has spread. And the classic framework for that is the TNM system. T is for the primary tumor's size. N is for lymph node involvement, and M is for metastasis, meaning it's spread to distant places. Let's start with T. So let's break down the T for tumor size. The cutoffs are pretty straightforward. T1, that's anything 2 centimeters or smaller. Easy enough. Next up is T2. This is for tumors that are bigger than 2 centimeters all the way up to 5 centimeters. This is a pretty common size for a cancer to be when it's found. And once that tumor gets bigger than 5 centimeters, we're in T3 territory. These are considered locally advanced cancers, just based on their size alone.
And then we have T4. Now, T4 is a game changer because it's not about size, it's about invasion. Any tumor, no matter how small, that's growing right into the chest wall or into the skin, causing an ulcer or that peau d'orange we talked about, that's automatically a T4. Now, before we jump to metastasis, we can't forget N for nodes. Nodal status is one of the most important prognostic factors there is. The key question is whether cancer cells have escaped to the lymph nodes in the armpit, and we figure that out with a sentinel lymph node biopsy. And that brings us to the final letter, M for metastasis. If the cancer has spread beyond the breast and the nearby lymph nodes, we call it M1 or stage 4 disease. And there are 4 really common places it likes to go. The bones, that's number 1 by far, followed by the lungs, the liver, and the brain.
Okay, but here's where things get really cool and really modern. For the longest time, staging was just about anatomy. How big is it and where has it gone? But now we know that biology is destiny. The tumor's own biological fingerprint can be even more important than its size, and the new staging system reflects this. It's a total revolution. So here's the key takeaway from modern oncology. The 8th edition AJCC staging system literally created a new formula. It takes the classic anatomic stage, your TNM, and it adds in those key biomarkers to create what we call the prognostic stage. It's a much, much better predictor of a patient's outcome because it's not just about where the cancer is, but about how it's likely to behave. So what exactly are we adding to that TNM? It's the stuff that tells us how the cancer behaves. We now officially include the tumor grade, how aggressive the cells look, and of course, the ER, PR, and HER2 status. For some cancers, we even factor in the results from fancy multi-gene panels that can predict the risk of recurrence. All right, let's put it all together. Quick summary of the entire workup, step by step. It starts with finding a suspicious mass and looking for those red flag skin changes. Step 2, you get age-appropriate imaging, ultrasound if they're young, mammogram if they're 30 or over. Step 3, any suspicious finding gets a core needle biopsy to get the diagnosis and check for receptors. And finally, step 4, you stage it using both the anatomy, the TNM, and the biology. So that's the framework we use today. It's powerful, it's personalized. But it really makes you think, right? As our understanding of tumor genetics just explodes, it leaves us with this big question. What's next? What are the new biomarkers that are going to totally redefine how we stage and treat breast cancer in the future?